Gutu Mission Hospital is the only referral hospital in Gutu district and was established in 1891 by German missionaries who later handed it over to Dutch missionaries in 1930. The same year, medical work commenced. Gutu Mission Hospital has an estimated catchment population of about 250,000 patients. The Mission Hospital as well serves as a referral center for more than 30 primary healthcare facilities in the district. Mukaro Mission Clinic, located 22 kilometers from Gutu, refers its critical maternal cases to Gutu Mission Hospital for specialized care services. However, Gutu Mission Hospital lacks the capacity to handle most of the cases as a result of lack of specialized equipment as well as specialists.
When we refer our patients to Gutu Mission, they are well received and they are also keen to take care of our patients, but sometimes we find they do not have enough resources to use. Like when the patient needs to go to theater, sometimes they say they don't have some of the things to use in theater, which means they will have to further refer patients to the provincial hospital. In the labor ward as well, when it's time for emergency, sometimes they have to call a doctor who is away, even to prepare for a patient for theater. You find that the theater nurses will be at home. If they would have a theater next to the labor ward for emergency cesarean sections, it will be safer because those ones you can just easily attend to the cesarean section after calling the doctor. Sometimes we might have patients with undiagnosed twins or could be a breach. They don't have a scan machine to check the patients, you see. Or even general patients, sometimes they don't have enough drugs, which means the patient will have to go to the growth point to buy medicines from the pharmacies. You see, they don't have enough drugs, even equipment to use in the labor ward. Sometimes we bring premature babies, they don't have incubators or they are not working, you see, which makes it difficult to send clients. But then what can we do? We just push so that they will just have. It's also difficulties in managing the patient.
Tine shortage yevoyo zvinhu zvakati wandei, like labor ward anonzi maresuscitate, patino resuscitatira vana kana mwana achinge abuda unotanga aiswa paresuscitate. Ipapo tinoona sokuti dzatinadzo hadzichanyatsoita zvakanaka. Panofanirwa kunge iri resuscitate ine panodziya, asi dzimwe nguva toona kuti inenge isiri kunyatsoita zvakanaka. Saka tinenge tichishuvira kuti dei tava neresuscitate dzakanaka dziri functional nezvimwewo zvakangowanda zvatingangoda rubatsiro nazvo, zvakaita selineni yavarwere, mishonga varwere. Dzimwe nguva tinogona kushoterwa nemishonga zvokuti tinopedzisira torifeya varwere kuti hama dzavarwere kundotitengera mishonga kumafamasi ari kwaMupandawana pano kuti vawane mishonga yacho pano. Dzimwe nguva inenge iri out of stock. Iyo wing yedu chaiyo, maternity wing, idoko, zvinoreva kuti dzimwe nguva munogona kuzarisa poita overflow yamapatients, mamwe achipedzisira takutomanesera muopposite ward inova female ward. Saka ipapo tinenge tine chikumbiro chigona yaiti wedzereswe kuitira kuti ikure. Mibhedha mishoma pari zvino, uye ndingangoti structure yepostnatal ward yacho idiki, saka inenge ichida kuti iti kukumuswe ikure.
We also have other facilities like the physiotherapy department. We used to have the X-ray. Unfortunately, the X-ray is down. The Mission Hospital covers quite a bigger area. So these other services are of critical need.
Kaya no Gutu Mission ne yama complications ya kamboitika before. Kamboitika last year ndakata mwana kashekera mudumbu ndiri pane shuro. Saka last year 2019 ndakata mwana ndikata operation pane pa Gutu Mission. But pandakaya pano asvikandifambira zvakanaka singaiti ndikwane shuro. Saka zvino ndaenda noona doctor akanditi ndiende kuscan. So ndifana kuenda kuscan neFriday kuitira kuti aone kuti mwana uno delivery mode yakamira sei, mwana unokwanisa kubudisika here zvaizvezvi kuitira kuti pasazowana zvinokanganisa kuti pawane one anorasikirwa nemumwe.
Kunoku ndakatransferwa pambambo neproblem yekuzvimba makumbo nekupisa nekuzvimba muviri ndikanzi ndiuye kuGutu Mission. Saka kubva pandakauya pano ndakagara 3 days kumubhedha, asi ndandatorapiwa zvava nani. Ndobva ndikanzi ndigozoona futi dhokita, ndikazomuona futi ndobva ndazondichindai kumatumba tirambe tichikuuchekai ndichiona kuti zvakamira sei kusvika nhasi.
The mother's shelter at Gutu Mission Hospital does not have some of the up-to-date facilities and comfortable trappings that have become commonplace in modern hospitals. The facilities are in need of an overhaul as pregnant mothers cook for themselves at open fires at the cooking shed. The rooms are usually crowded as many women are crammed into small rooms and they still use the bucket system for bathing.
Obstetrics is one area where things happen in seconds. 1 minute everything is okay, the next thing is things have gone haywire. If someone has not been trained in EMOC, they get a thought block. They have no idea what to do. They've heard about this before, they've seen it before, but in that moment the panic sets in and they have no idea what to do. And unfortunately, in a rural setup, majority of the times the personnel there is not a lot. And some emergencies don't come routinely. You can go for a year without meeting a breech delivery. You can go for a year without meeting a shoulder dystocia. Because of that, you tend to forget or you lose the skill of what you're doing. So when they get this memory, the moment that they meet this emergency in their scope of practice, they're calm, they're relaxed, they're able to manage it, and the outcomes improve for our patients. Some of the women we lose because the first person who meets them at their first point of call is not sure what to do. And as I said, things happen very quickly. But the probability of them surviving, the potential of them having a dire morbidity, which would be a burden on their economy, a burden on their family, a burden on their whole health system, this is actually reduced. And sometimes you're actually able to manage them at the primary level center. So that means they don't have to be transferred to the next place, because referral has got a whole lot of implications. A woman is going to leave their neighborhood, they're going to go somewhere else, the family has to follow them to check what is happening with them. That means time that has been wasted on the productivity of the family. It also means use of lots of money as they are transferring to the nearby town and all that. So it's got a whole lot of implications. When you train that worker, you've reduced this whole chain of events from happening.
Collaboration between the Reformed Church of Zimbabwe and EMAS Canada has started off a process that will hopefully see some assistance being availed to increase the capacity of Gutu Mission Hospital to handle obstetric emergencies within a largely rural setup.
These last 5 days have been quite an interesting experience for me. I've seen what an amazing resource Zimbabwe has in terms of expertise. There's people here who are very, very qualified with many years of experience. I've been able to observe how good they are at teaching in just the practical side of handling obstetric emergencies and looking after babies in distress. This conference coming out as a collaboration between the Reformed Church and EMAS Canada was in many ways an experiment, and being able to hear what people are giving feedback, the nurses, the doctors, and the nurses, it's been quite an eye-opener. One of the things I've noticed is people enjoyed the hands-on experience, the opportunity to learn by doing. But the entire experience for me has been one of just a great sense of joy. It's fascinating too to see how the teachers are able to spice the entire program with humor and the freedom and flexibility they have in interacting with the students. So on the whole, it's just been a tremendous pleasure for me to be here and as part of EMAS Canada to support this program.
Prof,